Everyone, and welcome to our webinar this afternoon. I'm really pleased that you can join us to hear from the speakers that we've got lined up today. I'm just going to briefly introduce myself and give an overview of the session that we've got coming up. And then I'm going to give you a little bit of background before we hear from the speakers. Sorry, apologies. I'm just going to try and share that again. How it's sharing. Great, super. So my name's Gwen Nightingale, and I'm an Assistant Director in the Healthy Lives team at the Health Foundation. And you're also going to be hearing from four really great speakers today who come from two different councils. We've got Anna and Neil from Barnsley Metropolitan Council, and then we've got Ansaf and Lorna from Oxfordshire County Council. So I'm going to give you a little bit of background that's just going to set the context to some of the financial challenges that exist. And I'm going to give a whistle-stop overview here before we hear more locally about the impact that these issues are having. And I'm sure that these will be familiar to many of you. So starting off, there's a perfect storm at the moment in local government. We've got reduced funding, increased cost of delivery of services, and all of that happening while there increased demand for services, which makes it quite a challenging time to work in local government. And all of these things mean that local government spending power as a whole is much lower, and it's estimated to be about 11% lower than it was in 2010 to 11, which is a significant difference. And while a general election provides an opportunity for a different national framework, whatever happens, it isn't going to change the challenging financial circumstances that councils find themselves in now and will continue to find themselves in. So the top line is that local government funding has reduced over time. And in more recent years, it's been topped back up again a bit with COVID grants, but they're not guaranteed to continue. And there's been a significant increase over that period of time. So even with that top up, councils would have been making cuts to services. And you can see from this chart that over time, as the central government grants have reduced, councils have become increasingly reliant on council tax, which can be challenging because that's a progressive tax that has a greater impact on people with lower incomes. It's also becoming more expensive for councils to deliver services. So there are lots of charts that you could show to demonstrate this, but this just shows how inflation's been growing over time, and particularly in the last couple of years, inflation's been very high. And a key component of services is pay, and things like increases to the national living wage have had an impact on the cost of delivery and the pressure that councils face. And alongside all of this, service demand is increasing. So within adult social care, there's increased demand for services. The same is the case for children's social care. And as an example, DLGA had shown that child protection inquiries had increased by 139%, and there'd been an £18,000 increase on child protection plans over 10 years from 2008. So there've been really significant increases at the same time. And spending on services like homelessness as well have also increased significantly. And between 2022 and 23, the amount that increased by 26%. So significant pressures. And then to top all of this off, we know that local government funding is not proportionate to need. So some funding that the Health Foundation funded, that the IFS took forward for us, showed that the areas of highest deprivation receive less funding relative to needs than areas of low deprivation. And there are lots of reasons for this. So even with the limited pot of money that's given to local authorities, it's not divided fairly and proportionate to need. And this can create challenges that are more acute in some councils. And I think we're going to hear a little bit more about this later. So given all this, it's unsurprising that many of the measures highlight the financial challenge that local government is facing, and we're in the heart of the storm. And in the annual survey of local government finance that the Local Government Information Unit complete, half of the councils that responded felt that they would be unable to balance their budgets in the next 5 years. And there are various measures, but there's a particular measure that's a £4 billion funding gap estimated over the next 2 years just for local government to stand still. And all of this means that lots of difficult decisions are going to need to be made, and indeed will already have been made by councils. And at the point that a council gets to extreme financial distress and is perhaps considering a Section 114 order, there will have been lots and lots of difficult decisions before that point, and difficult decisions will follow. And those decisions will impact lots of the building blocks of health, which is one of the things that we're going to be talking about today. So things like education, housing, green spaces, etc. And perhaps some of these decisions have been made in your local area and you can point to them. So in this environment, how can decisions be made that protect and support health so that we don't chase the immediate financial bottom line? And how can we create a break in the storm? And so I'm hoping that the excellent speakers that we've got coming up are going to talk a little bit about how they've been steering their ships through this course and the ways in which they've been building health into the decisions that have been made, the difficult decisions that will be made, so that it is proactively considered. So I'm now going to hand over to Neil, who is going to start talking about the experience at Barnsley Metropolitan Council. Thank you, Neil.
Thanks, Gwen. So just while Anna's loading those slides up, I'm going to provide some additional context to the national funding picture that Gwen's just mentioned, and because I believe that's contributed to the way in which we've approached embedding public health considerations into everything that we do here at Barnsley. So hopefully I'll come from a slightly different perspective, so I'm not to repeat what Gwen's already said. I'll hand it over to Anna and she'll bring it to life with some real life examples. So we can flick on to the next slide, please, Anna, once you've got them on slideshow. Okay, as Gwen mentioned, core spending power of local authorities, and just for the people on the call that aren't aware of what that means, that is that all of the core funding that flows into local authorities, so it's comprised of revenue support grant, business rates, council tax, and all social care grants. It doesn't include, interestingly, public health grant, but maybe that's a debate for another day. I think Gwen mentioned that's reduced over the last decade. Our calculations, this is a slide done by Sagoma, says that it's an 18% average real term reduction since 2010. But the point I wanted to make here was that this reduction's been far from uniform across the country. So the more deprived areas, as measured by the index of multiple deprivation, those areas have seen significantly higher reductions to their core spending power than those in least deprived areas. And you can see from this graph, those in most deprived decile 1, they've had average reductions of 26.6% as compared to 7% in the least deprived. So what I'll do next is I'll try to explain to colleagues how that's happened. Next slide, please, Anna. Oops, seem to have lost the slides.
Sorry, I never use Zoom, and basically I realised I'd muted myself and I couldn't unmute, but I'm just going to share my slide again. Sorry, Neil. And I had moved it on, but it hadn't moved on, but let me try again. Apologies, okay, no everybody. I'm shortly to get fired as Neil's Chris Whitty assistant here. Is that right now, Neil?
It is, yeah. You're not on slideshow, but
okay, I'm on slideshow on my screen. So
yeah,
I don't know
come from beginning on left-hand side. Yeah, that one.
Okay.
Okay, just click to the next slide then, please, and I'll do it that way. The purple one.
I'm really sorry, this isn't working for me. I'm doing everything I'm supposed to do and it's not moving on. So could Health Foundation colleagues, would they mind just doing our slides
no problem.
for us?
Sonia, you're okay to just share the slides.
Every time I move it in, it isn't moving on for anyone else. Thanks.
No worries.
slide 17, please.
Is that the right one?
It is, thank you.
No
So
problem.
yeah, just before I move on and explain the funding inequity, obviously I've shamelessly stolen this slide from the Foundation's own research, but the point of it is that there's obviously a clear link between deprivation and health inequality, as you all know. But from my point of view, I think that's a correlation made worse by the current local government finance system, and that's what I want to go on and talk about. Next slide, please. So how was this inequity transpired? And that's explained in the way in which the local government finance system works. So prior to 2013, most funding for local government came by a single grant, and that was distributed based on a complex suite of needs-based formula. Now, at the time, some people argue that the formula were flawed, but it did at least attempt to distribute money based on need. However, in 2013, that system was replaced with what's called the business rate retention system. And again, at the outset, that system also identified and assessed funding need for each council. But what the government then did was it estimated how much each council could contribute towards this by generating its own council tax and business rate income. Where that income was insufficient to fund that assessed need, an authority's funding would be topped up with a grant to make up the difference. Now, that's important because, as Gwyn's mentioned, during the period of austerity, it was core grant that was drastically cut. So what that means is the councils that were more reliant on grant from this system at the outset have faced much bigger cuts to their core spending power. And then the second factor creating disparity relates to council tax. So again, more prosperous areas can generate more income from council tax because they have higher numbers of higher value properties to begin with, but they also have a greater opportunity to subsequently grow those numbers at a faster rate than more deprived areas. Sometimes that's referred to as the tax base. So just by way of an example, a 5% increase in council tax at Wokingham, the least deprived area, raises an extra £130 per dwelling, whereas in Hull, the fourth most deprived area in the country, generates only £55 per dwelling. So that doesn't sound like a great deal, but when you look at the number of properties in those areas, that culminates in a £3 million per annum funding difference from the same increase in council tax. In addition, in more deprived areas, such as Barnsley, we tend to have more residents claiming council tax support. That's because of our relatively lower average incomes as compared to the rest of the country. That cost is funded fully locally, again, so that means less income to fund services in those more deprived areas. And then business rates, as I said, since 2013, councils have been able to keep 50% of all business rate growth, regardless of relative need. So obviously, you'll not be surprised to hear that the more economically prosperous places, they are able to grow their business rate income streams far greater as compared to more deprived areas. So I think it's a way of incentivising economic growth, which is what the government wanted, maybe, but a way of funding health and social care services for those areas that really need them the most. I mean, I personally don't think so. So I think it says broken system. I think for the first time in my career, there seems to be a broad consensus that the local government finance system is broken, but how to solve that in a way that's fair to everyone and in the context of an empty public purse, I think that's a problem that the government are going to find in its in tray shortly. Whereabouts in the in tray that will be, I'm not quite so sure, but next slide, please. I'll whiz through these because you'll have seen these before, but the point of these next couple of slides is what is this meant for public health and the other services that seek to tackle the underlying problems of deprivation and health inequality. So you'll all be aware that public health funding per capita has reduced by 20% in real terms since 2015. However, as you can see on the right-hand side of this graph, the impact has been much worse in the more deprived areas, where there are significantly more councils with higher than average per capita funding cuts than in the less deprived areas. Next slide, please. So what that has meant is obviously inevitable spending reductions in some areas of public health activity. But from my perspective and Barnsley's perspective, most notably in children's services, and that's at a time when there's a national crisis in children's social care. Next slide, please. So Gwyn mentioned that spend on statutory interventions for looked after children have risen exponentially in recent years, and they're really putting the significant pressure on all council budgets. But the spend in the most deprived areas, that's markedly higher than elsewhere, again demonstrating that clear correlation between deprivation, health inequality, and the demand complexity and cost of looked after children. And interestingly, the graph on the right, in my view, the result of the inequitable reductions in core spending power, ever increasing proportions of which are consumed by statutory social care interventions, means less money for preventative services at the time when the reverse ought to be true. So a false economy from my perspective, if ever there was one. Next slide, please. So what does all that mean for what we've done here at Barnsley to mitigate this? So our strategic planning, that's undertaken at a place, not an organisational level. So obviously there's nothing new in that, and it's by no means perfect, but deliberations at a place level have facilitated a genuine sense of shared outcomes, and we've got a plan of shared outcomes right up to the end of this decade at 2030. So our collective resources support the delivery of those outcomes, so they're not constrained by organisational boundaries, specific funding pots, or silo programme approaches. So what that means is that public health considerations, they're embedded right across parts of the place system, and it's not the purview of the DPH of Anna alone. And on a more pragmatic level, I think the real benefit for me is in bringing key stakeholders together to address common goals. And again, Anna will give you some practical examples of how we've done that in Barnsley in a second or two. The second thing is this council is known for its sound financial management. That's not because we're from Yorkshire or that we have better accountants than anywhere else, but it's because our senior politicians and officers, that they're not afraid to make difficult decisions where those are in the best long-term interests of residents. And that's important because it provides the organisation with stability and confidence. It enables us to focus on delivering good outcomes for people over the longer term, rather than having the annual scramble for budget savings that some authorities do. In terms of integrated funding, this might be a bit different to what happens elsewhere. In all material aspects, we treat public health grant and other specific grants as core funding here at Barnsley. So funding pots don't determine outcomes or interventions or services here. And also we don't view those pots in isolation. So, for example, when public health grant was cut between 2015 and 2019, we did the actual opposite of that here in Barnsley. We actually invested more than the cut in the grant between those periods because it was all about the outcomes. So, just in case anyone's concerned, we do respect the public health ring fence, but the grant is largely devolved across the organisation, so that allows it to sit alongside other funding streams. So for us, that enhances joint commissioning opportunities. And finally, as austerity kind of took hold and bit, we were no longer able to fund the universal services that we once did. So in response to that, we established our award-winning area council models, which through their area plans, they can commission hyperlocal interventions which are relevant to the current context of a specific locality. So, for example, schemes to reduce loneliness and isolation in areas where that's more prevalent. It still allowed us to do that stuff, but much more targeted. So that's our context. I'll now hand over to Anna to bring that to life. Thank you.
Thanks, Neil. Really appreciate that. It's a great intro. So I've been in Barnsley for 7 months now, so I'm kind of an insider and an outsider, so I'm kind of bringing it from that perspective. But as a DPH, it definitely feels like it's that public health is integrated right through the council. It's not an add-on, it's core to everything the council does. So I'm just going to give you 3 examples of where I feel that we particularly maximise public health outcomes based on making funding decisions in a slightly different way. So for my next slide, please. So Barnsley 2030, which Neil's alluded to, which is essentially lots of people will have this, where basically get together with partners, decide a strategy. But I think some of the ways that it actually plays out in Barnsley are really, really impressive. So the photo that you can see in front of you is our flagship shopping centre, so called the Glassworks. And obviously, as many of you know who come from towns, particularly in the north of the country, we're really desperate to get that footfall up to maximise the Barnsley pound. But obviously, we also want to achieve better health outcomes for our population. So one way that Barnsley Partners work together is they put the clinical diagnostic centre into the next slide please, into the Glassworks. And what they've seen is that residents, instead of having to go to hospital for their breast cancer screening, etc., which can be quite stressful, and particularly we saw a real dip off, didn't we, in screening rates after COVID, they actually can go in and have a really nice shopping experience, and at the same time they can get their breast cancer screening. So we've seen a 25% increase rate in breast cancer screening at the same time as we've seen that increased footfall. And some of our businesses have really got behind this and do things like offer a free coffee for people who've just had breast cancer screening and other screening procedures. So for me, that's such a good example of like maximising your bang for your buck, getting those public health outcomes, and really sort of increasing benefits for everybody. Because as a director of public health, I want thriving economics, I want to maximise the Barnsley pound, and I want to get people integrated community cohesion, all those things going on in the town centre. So next slide please. So we're now taking this a step further. So we've bought the Alhambra Shopping Centre, the council have bought it, and the whole of the top floor is going to be turned into Health on the High Street. And there's a number of partners involved: the hospital, local primary care, voluntary sector, leisure services, and really it's extending, taking the Glassworks and the CDC one step further. Again, there's real benefits for the hospital here, because as you all know, one of the reasons why people go to hospital is because it's close to their home, it's familiar, they're already there for perhaps an outpatient appointment. So by moving a lot of outpatient stuff into a shopping centre in the town centre, you're encouraging people not to access the hospital unless they absolutely have to. You're moving the norm. And also there's just practical benefits, car parking, again, putting money into sort of the local council, that can then benefit the public through additional services. So it's a really good example of, I think, maximising public health outcomes, and not a penny of this has come from the public health grant. It's all been funded through other funding streams. So next slide please. So the distributed public health model, and again, some of you who were in public health in 2013 will remember moving from the NHS into local authorities, and a lot of us did a lift and shift model. So that where I was working in Wakefield, it was lift and shift. And I think when we heard about places like Barnsley, who kind of quite bravely sort of moved people right across the council, I think the word brave was used quite a lot, and there was kind of some nervousness around, would that dilute the public health offer? Would that be a way of getting rid of public health staff? But actually it's worked brilliantly here, I think in part because they've put really senior posts into different directorates who are kind of a core part of the directorate management team. And I'm not going to go through this slide in depth because you can read it, but there's been some real benefits around strategy development, maximising income. I think as well, just thinking about the skill sets of the different teams within the council. So we know that our sustainability and growth directorates, or sometimes called economic growth and regen, are really, really good at fundraising and also get a lot of grants in, particularly for capital programmes. So by having those staff sat within those directorates, we've been able to maximise things like physical assets, infrastructure, and that, I think, it's made a massive difference. Next slide please. So a good example of this for me is our sport and physical activity team that are based entirely within growth and sustainability. And again, I'm not going to read the slides, but I don't know about any of you public health people out there, but for years I've tried to get my sticky fingers onto Section 106 funding, never managed it. But here, that team have managed to, as you can see, access lots of the 106 funding to improve infrastructure for physical activity. The purple box on the bottom right really demonstrates, I think, exemplifies the Barnsley's approach. So you've got quite a small amount of public health funding, just 85,000, a far more significant amount of core funding, which, as Neil said, they've sort of topped up the public health grant with, and then they've managed to lever in almost half again of external funding. So again, that exemplifies the model right across the council. And again, to me, it's just showing how you absolutely maximise that public health spend through working really effectively and placing people in the area that they can have the most impact. So next slide, please. So map of Barnsley. I like this map because I think it's proportional universalism in real life. So on the left hand side of the map is our much sort of wealthier, less deprived area, better health outcomes. The right hand side of the map is our much more deprived areas, and the little purple bit, which is the Dearne, is our most deprived area. And you can see how the way that they've done the area councils means that proportionately the smaller, more deprived areas get more bang for their buck. So we've got, for each of those areas, we have an area manager, and we have a number of other staff delivering community development type interventions, and we also have this grant pot that Neil described. So next slide, please. So this model was set up in response to austerity. Again, I know a lot of you, certainly previous councils that I've worked in, a lot of that area working just went. But I think what they realised here is that and we know this, but we don't always do it, that it's far more sensible to make decisions as close to people's homes as possible. Elected members, local residents, community development workers understand their area much better than a more centralised model. So what they did was they set up area councils, devolved 2.1 million to those area councils. That's across, so that's not 2.1 million each, obviously that's across the whole of the borough, but they've maintained that value. And actually, even with some really difficult conversations that we're having at the moment, we're maintaining that level of spend into those areas. And then public health work, so this all sits under my sort of in my directorate. So we work closely with those local area councils to look at what's the need, using things like the JSNA data, sort of soft information, and then they micro commission things into those areas to respond to that need and really provide that early intervention and prevention type activity. And the other thing they do, because obviously volunteering is really key for a number of reasons, so they lever in more volunteering by you need to match fund some of the smaller grants, but you can use volunteering hours to do that. So next slide, please. So you'll be aware that particularly in more deprived areas, you tend to have lower rates of volunteering. But I think this was a year's outputs from this local area model, and again I think really impressive and really demonstrates some of that value that sort of non-monetary value, but real sort of social capital that we're able to harness. Next slide, please. So Goldthorpe is one of our most deprived areas in terms of housing. So kind of lots and lots of renovation happening now, but quite traditionally quite an area of quite poor housing. And you can see these pictures here. None of us would want anyone to live in these houses. But one of the things that the Dearne Council have done is they funded additional housing officers. So this is through their devolved budget. And I went out with one of them. They literally walk around the streets, not quite looking in windows. That sounds quite bad. But, actually noticing, has the post not been collected, spotting signs that there might be some support that the council need to give. And these are some of the houses that they've discovered, particularly through private rented, which is obviously a massive issue. And so they've worked with the landlords, and they've sometimes had to prosecute. But there's a really good stat that I want to share with you, which is that of those 6 officers, they've got 6 officers funded in total across the borough. They've picked up 25% of the housing demand at that really early stage. And we all know as well that for people that live in that sort of housing, often the first time we hear about it is, they're hoarders that very sadly have had a house fire, or they're admitted to A&E because they, have got really severe respiratory symptoms. So again, it's that really demonstrating that very early intervention, working in local areas, devolving budgets down, and therefore maximising outcomes, public health outcomes for your population. So I think that's me done. So I'll hand over to my colleague from Oxfordshire.
Chloe, do you want to continue the slide deck? Probably be easier.
Sure, that's fine. Sonia, are you okay to get that back up then? Okay.
Yeah, that's not a problem.
So while the slide decks have been put up, so I'm Ansaf as a Director of Public Health for Oxfordshire. It's great to be able to talk at the Health Foundation around how we are doing things in Oxfordshire. I've got my Executive Director for Resources, Lorna Baxter, who is also our Section 151 officer. What I want to do is to really give a Oxfordshire perspective. I think you've heard a lot from Neil around the general climate around, really useful update around the general climate around the funding cuts. What I'd like to do is to kind of translate that into how that means, how that impacts in Oxfordshire, which is a different area to Barnsley. So Oxfordshire is a 2-tier county, and have got 4 districts and 1 city council within it. So it requires a different approach in a lot of ways. So next slide. So what we will do is I'll talk to you about, I'll give an introduction about what is the health in Oxfordshire like. Lorna will talk more broadly about the financial context in Oxfordshire, and then the council vision as a whole. And then I'll come back in again talking about some of the tangible things at a very high level, what we're doing locally to protect the health and well-being of our residents. Next slide. So next slide. So if you stop there, so Oxfordshire, for most of you probably see Oxfordshire as one of the most affluent parts of the country. It's considered the 10th most affluent part of the country. It's a big place, population of over 700,000 residents. Like I said, 4 district councils, 1 city council, significant rurality in Oxfordshire. But when you look at health outcomes, as I've demonstrated there, whether you're looking at life expectancy, or whether you're looking at childhood obesity, or whether you're looking at premature mortality from preventable causes of illnesses, Oxfordshire is better than national average. So it looks really good in terms of the public health outcome. But Oxfordshire does have 10 wards within Oxfordshire that are in the 20% most deprived in England. So if you go into next slide, if you repeat the same indicators for those areas, you see a very different picture. So they're all worse than the Oxfordshire average, and they're also worse than the national average. And if you look at our demand to our health system, more broadly, they come from these areas. So you get a completely different picture. So it becomes really important that we have a targeted approach to these areas, which are actually quite different in itself. So this led to for me doing my first Director of Public Health annual report 4 years ago, just before COVID, where we highlighted this and shined the spotlight on this specific issue. And what led from that was that we did what we call community profiles for all of these wards. And so there are 10 wards. So we have produced 10 community profiles. For each of the community profiles, we gathered the data almost like a mini JSNA for that area. And then secondly, we spoke to the community and gathered community insight. And thirdly, we mapped the assets that are available to that area. By doing these 3 things, we were able to identify gaps and then address some of these issues in a way that is unique to that community. So to give you an example, for pretty much all of this area, childhood obesity is a significant issue. For an area like Banbury Ruscott, it might be related to language barrier, whereas for another area, it might be related to routine manual workers, white working class workers. So you take a completely different approach to a same problem, if you like, a same public health issue. So as a result of this work, we commissioned 10.5 whole-time equivalent community health developmental officers to take these recommendations and directly act on them with our districts and city partners. We have to do this with our districts and city partners who have got absolutely some of the really important levers to pull. Next slide. So you can see here from the inequality perspective, Oxfordshire as a whole is better than national average for when you look at our life expectancy. But actually, those 10 areas in red, you can see they are significantly different. So breaking it down to district level, you do not see that that variation. You really have to go down to ward level to see that. Next slide. And just to highlight the problem more closely. So emergency hospital admission, whether you talk about emergency hospital admission or childhood obesity, again, these 10 areas constantly feature. So you see the red line, which is the Oxfordshire average. The blue line is the England average, and then you have the colored bars, which are the districts and the city. So you see the difference in these 10 wards when you're looking at whether it's a health-related emergency admissions or whether you're looking at a lifestyle issue like obesity at the age of 6. Next slide. Same with education and skills. If you once you start looking at some of the wider determinants in terms of levels of development at the age of 5 years, you see the same picture here. Next slide. So the key in all this is that we in Oxfordshire, you've got this kind of story of two halves. You have got very high levels of affluence in one part, and then you also have some significant inequality and deprivation. And you know, this for some of you, this is you'll be familiar with this. The drivers for this inequality is largely driven by socioeconomic and environmental factors. And that is why we have taken an approach in Oxfordshire that really takes into consideration the place shaping element for these areas in terms of tackling the drivers of this inequality. So that's just a really good overall view of the Oxfordshire challenges from a health perspective. I'll bring in Lorna to talk about our financial and context and our council vision.
Okay, thank you. Next slide, please. So I'm going to only touch very briefly on the financial position because Neil covered a lot of that in detail. And even though we're a very different authority, obviously funding reductions have been in place across all councils in England since 2010. So it's a similar position. I wanted to start in terms of our strategic plan, just in that it really helps drive our approach because our vision is about becoming a greener, fairer and healthier county. So we are effectively start by the focus in terms of our vision. The vision is then supported by 9 priorities, and 2 of those include tackling inequalities in Oxfordshire and prioritising the health and wellbeing of residents. So you can see that even at the sort of the top level in terms of the organisation's ambition, that we are driving those health linkages and improvements in health. Next slide, please. So then beneath the vision is our organisation ambition. And our organisation ambition is to become an employer of choice, a partner of choice and a place shaper of choice. And the reason that's important is because we want to ensure that we are the right organisation for partnerships of all shapes and sizes so that we can deliver the best outcomes for our residents. And where partners feel that we are supporting them and are supported by us. It's also then about bringing together public, private and community groups to help shape the county. One of the things that we are really focusing on is that we don't think that the organisation should itself be the first, middle and last provider of all of our services, and that there are better ways to deliver that. And also obviously thinking about focusing on our residents and the pride in where they live and are happy with the services available to them. And that's also really important in terms of thinking about some of those health outcomes and benefits. Next slide, please. And as I talked about in terms of our partners, this is not something that we're approaching on our own. So our ambition on a place shape approach is obviously working across the NHS system, but also across our districts and the City Council, but also some of those other wider partnerships that we have in Oxfordshire, which include all of the district and the City Councils, as well as things such as the Local Enterprise Partnership and a new body, which is the Oxfordshire Inclusive Economic Partnership. As Ansaf has said, it's a different approach in Oxfordshire, being a two-tier area, so collaborative working is extremely important because we have to work together to drive and deliver the outcomes that we desire. Next slide, please. So very briefly in terms of our spending, so our budget for last year was 897 million. You can see that actually public health improvement preventative services only is about 5% of that. So as was set out earlier by Neil, significant spend in terms of adults and children's social care. So it's really important in terms of our approach, linking back to our vision and our priorities, that we maximise the benefit across all of our service areas. So we also think about how we link across in terms of our capital programme. So things like our active travel programmes, where we've been successful in attracting government grant, obviously thinking about how those schemes can help benefit healthy lifestyles and healthy place shaping. Just the next slide, please, just then really just shows, I won't really focus on this, but this is about the challenges in Oxfordshire. You can see just a couple of slides showing the reduction in our funding, the increase in the amount of savings that we have had to deliver over the last 10 years or so, particularly focusing on the fact that rising demand has resulted in a significant reason for making those challenging savings. On the back of the fact that we've got not enough workforce in Oxfordshire to deliver on some of our services, and the issue around high inflation and rising demand. So all of the challenges that are made reference in Barnsley, obviously in a different context, but still a challenge for Oxfordshire in delivering our services to our residents. So how do we approach the sort of embedding and linking the vision and our priorities to our budget? So the next slide sets out our approach. Effectively, what we're doing is looking at a 4-year planning cycle on the context of understanding the local government finance settlement alongside the strategic priorities and the challenges we have, particularly in Oxfordshire, linking in that ambition to become an employer and plate shaper and partner of choice. So we've got that feeding into the business planning cycle, but then focusing on an understanding of our data. Obviously, ANSAF made reference earlier in terms of those 10 most deprived wards and how we focus our priorities in relation to that, our localised pressures, thinking about how we compare with other authorities and where we can improve the focus and what we're trying to do. We have a significant transformation programme that's looking at improving the amount of digital focus that we have, improving our processes, improving the ways that we work, also shrinking the organisation, as I made reference to, about not being the first, middle and last provider of all of our services. So thinking about that vision and how we translate that into that 4-year plan, and effectively what that then tries to do is to have an organisation-wide understanding of priorities, medium-term impacts linked to the medium-term financial strategy, as well as the vision and the priorities, and really importantly, trying to align our funding to our priorities, protecting those priorities where they are priorities, and then investing where we can. And obviously that is often on an ad hoc basis. So we were, on the back of the funding settlement for last year, able to use some of the additional social care funding, for example, to do some pump priming for improved outcomes, particularly across adults and children, that also then has a direct impact in terms of the wider health benefits. And all of that supported and challenged through a staff chamber process on a quarterly basis that allows us to challenge and check that we are delivering against those priorities. So that's effectively how we try and align the two in terms of the financial approach, as well as linking that through in terms of the priorities. So I'm going to hand back over to ANSAF now.
Thanks, Lorna. So I'm going to talk a little bit about how our approach within public health and across the system in terms of addressing this issue. Neil talked about the reduction in public health funding in real terms. In Oxfordshire, over the last 8 years, we've seen a real term reduction of 25% roughly over the 8-year period. So it is significant. But so public health budget in Oxfordshire is about just over 30 million. If you then compare that against a local economy across Oxfordshire, if you bring in the county council, the acute trusts, our budget, we spend roughly around 5 million a day. So that's the context in which we're talking about. And then it becomes about how do we actually influence the wider system to deliver on the public health agenda. And one of the things we looked at is we looked at the public health structure. We've aligned our public health structure to influence the system across the life course. So I've created a leads for Start Well, 2 Live Well, and 1 Age Well. So we have clear individuals at a consultant level who will influence the children's agenda, the adults agenda, as well as the aging well agenda across the council and across the public health as well as the health system. And that's really important, because if you look at the public health budget, and I would say, I'm sure Anna would say the same thing, 90% of public health budget is spent on statutory mandated functions, quite a large proportion. So it leaves you only a very little to influence the wider determinants. And in addition to that, in Oxfordshire, we feel the importance to have that kind of a partnership approach. So we have a lead for partnerships and tackling inequalities. We have the lead for healthy place shaping, who is in public health, linking up with our environment and place colleagues to really drive the regeneration agenda from a health perspective. And we also have a policy-led research strategy which mobilizes the Oxford University and Oxford Brookes University to look at internally in terms of what things we can do innovatively to tackle health inequality across Oxfordshire. So we've got some really good systems in place to really influence the wider agenda. The key, I mean, there isn't a silver bullet here, but the key here is about how can we work across the system to get the system to deliver public health agenda. And we saw some examples when Anna talked about it, how she was doing that in Barnsley. Public health also has wider responsibilities in community safety, domestic abuse, and the wider prevention work across the council. So that's overall what the public health structure looks like. It is embedded across the council and across the system within Oxfordshire. Next slide. One of the examples, the tangible examples of that I want to talk about is Oxfordshire Way, an approach that we take, and to give you an example of how we work across the system. This is not a county council initiative. This is across the Oxfordshire initiative. It was started off by the adult social care team with the support of public health. And the whole idea is that it's about providing people with the ability to support themselves without not needing the statutory care. So it's community-led. We want people in Oxfordshire to live within their community, remaining fit and healthy for as long as possible. And that means empowering the communities, active lifestyle groups, online support, informal supporting networks, so enabling all that. And that also means that when they require early intervention, it happens quickly and early. And then also minimize the need of formal support as a result of that. And that becomes massively cost effective. It also means that our population remains independent and healthy for longer. Next slide. So Oxfordshire Way has been a really good example of how we work across the system, across the care system, to deliver more upstream interventions. And we have already started to see some significant results, a reduction of 31% of people waiting for social care assessment, and 22% of older people in Oxfordshire receive direct payment compared to 15% nationally. So they're living more independently at home. So you can read it there. There's plenty of examples of how this has really helped to move interventions upstream, therefore doing things in a more cost-effective way, and also keeping people healthy and independent for longer. Next slide. In terms of working across the system, one of the things that really I was inspired by coming into Oxfordshire is the healthy place shaping approach that we have taken. Back in 2016, the Healthy New Town initiatives came up with 10 healthy new towns across England. And 2 of them were actually in Oxfordshire, Barton and Bicester. And that bought into the principle of when you're doing regeneration and development within an area, you do it from the health lens. And actually, the whole principle is about creating a place which promotes healthy behaviors and making it the cultural norm to stay healthy and to be healthy. And that is a principle that was really well integrated across Oxfordshire. We have the lead for healthy place shaping, who's building on that and expanding that to other areas, particularly the 10 areas that we've talked about earlier to tackle health inequality. We spend in public health commissioning lifestyle services that are quite expensive to try to change people's behaviors. When some of these behaviors, whether it's smoking or whether it's eating unhealthy food or physical inactivity, they're already quite strongly embedded within their day-to-day lives. So it becomes harder to change that behavior. It would be much better and cheaper and less expensive to shape the place that promotes that healthy behavior in the first place, so that we do not have to spend huge amount of money on commissioning services to change those unhealthy behaviors. So that's the whole principle of healthy place shaping. It has 3 key areas. So if you go into next slide. So the 3 key principles was born out from the Healthy Newtown initiative. So the first one is the built environment. Of course, there's lots of development in Oxfordshire, and it's a great opportunity to work with planners to change the built environment in a way that promotes healthy behaviors like the way I just talked about. But building an environment in itself is not a solution. You've got to activate the community. And community activation is the second pillar. And then the third pillar is new models of care. How do we deliver care in a different way? I've talked about Oxfordshire Way earlier. That's an example of new model of care, how we deliver care in a more self-supporting way to keep people independent. There's the social prescribing element. So this started with Bicester and Barton, where we've got lots of models of examples of how we have delivered that. And now we are looking to expand these initiatives in other areas of development like Didcot, as well as areas of deprivation like Banbury. Next slide. So this gives you a little bit of why built environment matters. Be more physically active, feeling safe and secure. When we did our community insight profile, it was clear that a lot of our areas of deprivation, they've got these parks and access to green spaces, but they did not feel it was secure, and that in itself meant that they did not use these fantastic assets that were available to them. I think some of these changes will take longer to show effect, but ultimately with the new business planning method means that we are looking at 4 to 5 years, mean that we'll be able to embark and invest on these kind of things to be able to actually make a real difference and make structural changes. Next slide. So I already talked to you about community activation, the importance of community activation, and there are some areas where changing the built environment is not possible, and that's in those areas it's about actually following the community activation models. Next slide. And then this is my last slide. So overall, in addition to doing some of the healthy place shaping initiatives, which is starting to make a real difference, and we're taking a longer term view on that, the other thing we're also doing is that it's about influencing the NHS system, our health system, and taking a bit of a system view. So most recently, we produced a health and wellbeing strategy with 10 key outcomes, which was agreed across the 5 districts and city councils, across the health partners to deliver, which is relevant to all of them. And they can see the positive impact for their area. The key in all this is to be able to evaluate and show a difference. So there are initiatives in the local government that actually helps to reduce hospital admissions. So we've got something called the Prevention and Health Inequality Forum, which we chair, which is across the place, across the system. We've used NHS money to support things like better housing, better health initiatives, to support things like Move Together program, which is about people with long-term conditions, getting them to move more and therefore reduce the need for health services. We were able to evaluate this program and actually show the reduction in hospital admission and reduction in health utilization as a result. And I think we need to do more of these type of evaluation to show that benefit to the health system through the local government initiatives. And this has enabled us to have different conversations with our health partners. So you would also see that in my recent Director of Public Health annual report and my previous annual report that I've just talked about around inequality, I often use the Director of Public Health annual report to bring the wider system together to create a call to action, specifically our health partners, to understand what we are doing in local government can make a real impact. So I've touched on some of these things more broadly, but I'm happy to take any questions. Thank you.
Great. Well, thank you all for such fantastic presentations. A reminder for everybody who's on the call that we've got the Q&A function where you can ask questions and upload the questions that you'd like to vote for if there are some things that really resonate. And that was kind of, I think for me, it's always fascinating to hear about the approaches that local areas are taking, and particularly when it's about how health is being embedded into all the work locally. It's really great to hear. And there were certainly some common themes that came through about the importance of communities being involved and decisions being made close to communities and that kind of meet their needs. But I wonder whether perhaps I could start the first question with a question from Bryony around how you get people to invest in Section 106 money was her kind of specific question, but I suppose more generally, how do you get people to invest in the wider determinants of health? And I wondered perhaps Neil and Ansaf, if you could kind of let us know what's made a difference. So Neil, kind of, was there a moment where this kind of just really resonated with you coming from a finance background? And Ansaf, was there a kind of a point where in Oxford there was a tipping of the balance where perhaps some of this agenda was being taken more seriously and people wanted to invest and get behind it? So Neil, over to you first.
Sorry, I did miss a little bit of that. You were breaking up a little bit, Gwyn, but I think I got the basics of it. So it's back to what I said in my slide deck. I think if you've got a place-based vision where everyone's working to the same outcomes and the resources flow to those, then that's how you make the case, because it starts with a shared sense of priorities. But in terms of specifics, and they all flow from those outcomes. So those will include health outcomes embedded within the outcomes framework. So when we're making the case for investment, it's not your traditional, business case based on, a commercial return on investment. It looks at the things that you've just mentioned in the broadest sense. So of course, it'll look at the finances and what things cost and what you might get back from it, but it'll look at the economic regeneration impact. It'll look at the health inequality impact. It'll look at things like no-shows for appointments and things of that nature. So when we make investment decisions around things like health on the high street, we'll look at things in the broadest sense, but it all comes back to having that place-based outcomes framework. And if it's not contributing to that, we won't consider it in the first place. But because health considerations are embedded within that, it means that we do.
Great, thank you, Neil. And Ansaf, from your perspective, kind of, was there a tipping point in Oxford where people seem to get the agenda outside of your public health team? Oh, you're just on mute.
Oh, there you go. Cool. So Section 106 it's challenging because we had to work with 4 districts and city council for our Section 106 money. But I think the best way around this in Oxfordshire is that we work with our environment and place team, who work with the districts and city to develop whether it's housing initiatives. So when you're doing these things, considering around access to green spaces, improving physical activity, and through our healthy place shaping team, we are able to influence that agenda with our districts and cities. So our lead for healthy place shaping not only works with the environment and place team in the county council, but also works with the districts and city to influence the local plan. So that's our avenue for influencing the agenda in Oxfordshire.
Thank you. And this is a good opportunity for me to plug 2 Health Foundation resources, which will come up on the slides at the end. The first is a toolkit that we've developed with Frameworks Institute around how to have conversations about health. And the second is some infographics, which are hot off the press from last week, which are resources that we'd love you to use for free to help tell the story about why the wider determinants are healthy. Oh, thanks. Chloe's just popped those in the chat. So I'm going to move next to Anna, and kind of sticking with the theme of working with others. There's a question about how do you keep people up to date with all the great work and the focus when there's so many moving parts in the system and people change roles and structures change? Kind of, have you got any tips for how you've done that well in Barnsley or in previous roles?
Yeah, so obviously no one ever leaves Barnsley because it's such an amazing place to work. So we don't have quite the challenges that other areas have. No, I suppose there's that. I think that is a real challenge for elected members, particularly in their particularly around the ward and the local area council model, because they want to know, obviously completely understandably, they want to know everything that's going on in their place. But part of what we're trying to do is stimulate community activity and let it take on a life of its own. And that can be a bit of a challenge. I mean, we have all the kind of normal stuff. So the physical activity stuff has its own kind of web page with everything on, and then individual groups can kind of put stuff onto that. I think trying to use some sort of informal mechanisms as well. So just from a personal perspective, I do an update to all of my team every Monday, and I always kind of put everything into that. I think relationships are really important. I think so when you've got trust, which I think the area council model lends itself to, because you've got staff working with people on a daily basis. So I think that builds trust with elected members. So it really facilitates good communication, which, to be honest, a lot of the time isn't about stuff that's written down. It's about that talking to people, capturing those coffee conversations, which again, I think sort of the previous conversation, it is about having written strategies, but it's also about understanding the work of other teams, and that's often created by co-locating people or putting people as a key member of that team, and that's where you build the trust, and that's where you understand the agenda, and that's when you kind of get the shared outcomes from. Yeah, I guess those are kind of a few things.
Yeah, and I think certainly that trust in kind of in any relationship where you're working with others, that trust is really important. And I think even more so when you're trying to win over somebody who perhaps comes from a different position or needs some encouragement to get to that point. Yeah. Also, kind of a slightly different take on stakeholders. Lorna and Neil, I wonder kind of what your reflection might be about other people in the system who have or haven't got money. And there's a question about how the council's working with the Integrated Care Board. And you're both in a position where you've got your own pressures and your own primary focus. Can you give any insight into kind of what's working well, or perhaps what some of the challenges are and what you're trying to do about it?
So I think it goes back to the point that has been made. I think trust and relationships are key in any environment, in everything that you're trying to do. So I think the other thing as well that we have found from our perspective is that sometimes it doesn't need to be interventions that cost a lot of money. They can be really small schemes that can sort of make a really big difference. So we do have a place-based partnership, and we do obviously work together. But I was just thinking about one of the examples we've got where we spent a really small amount of money in terms of a co-produced scheme. It was about putting in a sort of a bench in a park that was accessible for young people, that attracted them to the area that they otherwise wouldn't have used. So it was a really good example where it's something small, obviously worked in collaboration with partners and also with young people, but can make a real big difference in terms of attracting people to that environment and getting them out and about and getting them healthy. So sometimes it's not about the big money, but about those relationships, co-production, and those small things that make a big difference.
Yeah, Neil, from Barnsley's perspective, have you got any reflections on kind of where there are good things to build on, or perhaps some of the challenges and how you're approaching them?
Yeah, thank you. So I get the sentiment of the question that's in the chat. People often retrench, don't they, into their own little silos when money gets tight. So I do get that. But I think if you've got a genuine sense of shared priorities and good governance and working arrangements around that, you can really work through some of these things. So I'm personally involved in working with our ICB about looking at, improving the end-to-end journey for some of these stuff. So we're currently looking at respiratory stuff. We're currently looking at, I can never say this word, circulatory parts of the system. So what we've done is like identify 3 or 4 priorities where we think there's a fundamental opportunity to change what we do across the system. So I think we tend to look at it, you know, as a system. I think that's what you should do. But I get the point that, you know, often people retrench. So I suppose what I'd say, my reflection is that you should always think about the bigger picture and keep pointing that out to people when that might happen.
Yeah, that's really helpful. Thank you, Neil. And I think with public health, sometimes, and issues around health, sometimes the challenges can feel so massive that there can be quite a depressive narrative around some of the issues. And I think there's something really important about looking for those things that are doing well and building on the successes. And the same goes with the relationships, to kind of focus on, well, you know, what can we do, and that, rather than kind of where are we pulling apart. We've had a couple of specific questions, which I think we'll try and take some of those offline, and we can kind of follow some of those up separately. But I think the last question that I'd like to ask all panelists is kind of related to government finance generally. Is there anything that colleagues from local government finance on the phone could be doing to influence having more proportionate allocations, kind of the local government funding situation? And there was another question as well about kind of, did people think things were going to be different after the election, and how? And there's quite a lot of news, noise this afternoon about the election coming before the summer, so it might be happening sooner than perhaps anticipated at the beginning of the week, who knows. But yeah, just perhaps people's really quick reflections on, is there anything that people on the call could be doing to be advocating for a better system going forward? So perhaps I will start with Anna.
Brilliant. Yeah, I mean, clearly we need a radical reset of the system because it isn't working and it isn't fair. And I think, you know, the great British public, they understand, they want fairness, and I think at the moment we can really see that that isn't happening. I think the other thing that people often forget is that a fairer system is better for everybody. So if you look at countries like Brazil, which has a really unequal distribution of wealth and resources, that for both rich people and poor people in Brazil, it can feel like a really difficult place to live. And I think that the more equal our society, the fairer it is, the more the resources are distributed equally or equitably, the better it is for everybody. And I think, you know, with a new government of whatever politics coming in, is a real opportunity to actually reshape that agenda and listen to our population and actually make things fairer. And you know, no one would want any child born in the UK today or tomorrow not to have the same chance of a great life as any other child. And I think that's what we should be aiming towards, thinking about future generations and radically improving our funding, and obviously giving loads more money to public health, of course.
Well, that goes without saying, Anna. Thank you. Lorna, have you got any brief thoughts to add?
Yeah, so obviously I really support what Anna said, so I won't repeat any of that. I think there's another couple of things that we really should be asking for, which would really help, such as longer term funding certainty. So obviously we get public health grants, as many other grants, just announced for a year, which means that it's really difficult to plan for those longer term solutions that drive those big impacts. So that'd be something I'd want to look for. And less bidding for grants. You know, it's time consuming. It depends on how well you do fill in the grant applications. It's not fair, it's not consistent. And also a better link between capital and revenue funding. So, you know, some of those things I was talking about earlier in terms of some of those smaller interventions, sort of using capital funding as one-off, provide some really big impacts. So some better join up and thinking between capital and revenue funding.
Great, thank you. And Neil, have you got any additional points to briefly add?
Yeah, I mean, look, it's a wicked question. That's local government's an extremely complex landscape. I mean, because it's interesting, we've got Barnsley, we've got Oxfordshire on, and places are so different, and the cost drivers are so different. So what's good for one place in terms of how money's dished out is not good for another place. So the reason this doesn't never get sorted is because there are always winners and losers from any reset. And I mean, I'm a big part of my role is lobbying government for my area. So I do understand this quite a lot of detail. But I suppose the one takeaway for me in this should, you know, everyone should agree with this, is whatever money there is available, there surely should be a better way of distributing that so it follows need than there is currently. I suppose that would just be my key takeaway.
Right, thank
a properly
you.
funded system, because at the moment the system's not funded based on need, it's funded based on relative need, and not a lot of people understand that. So first of all, fund it based on actual need, not our need relative to Oxford's needs.
Yeah.
That's the first thing, and then whatever money's in the system should better flow to that need. So that'd be my key ask of people on the call.
Yeah, great, thank you. And Ansaf, have you got one ask, or have the panelists beautifully covered everything that you were thinking of?
I think Lorna alluded to this. For me, the big thing is that we got a new government. If there's going to be a new government, it's that kind of longer term view on this. It's critical, because yes, you know, there'll be winners and losers in terms of our funding pot. But if we can actually embark on a longer term, and I'm talking 5 years plus agenda around tackling some of the drivers for inequalities, and then have a devolution plan that's attached to that, you're able to do things in a much more consistent and sustainable way.
Mm-hmm.
And I think that has been the constant challenge. And I think it is incumbent upon us to make the case for it. With you know, whichever government that will present itself to us.
Yeah, great, thank you. Well, thank you for that, and thank you for your excellent contributions and presentations throughout the session. I was just going to finish off by sharing a couple of resources. So the toolkits that I mentioned earlier, and then the infographics, the links will be in the slides that you get through. We've also got we've got quite a lot of data around the building blocks of health that can be accessed through our evidence hub. So if you're not aware of that, that might be something to have a look at to kind of help make the case to people in your local areas. And then also newly launched a couple of weeks ago, we've got a local authority dashboard, which drills down into local data, looking at what builds good health. So that can be quite interesting to see what the situation is in your local area and to make some comparisons. And then finally, if you want to keep in touch with the Health Foundation's work on local government, then please do sign up to our roundup, which is, I think it's 4 times a year. It won't spam your inbox too much, but you'll see all of the work that's going on. The webinar's been recorded, and so you'll be able to watch it back again if you'd like to, or share with colleagues, and it will be available on demand soon on our website. And please finally do fill out the post-webinar survey and look out for the future webinars that we'll be having tailored for local government audiences. The next one we've got planned is on risk factors and what local areas can do to tackle issues around alcohol, for example, and obesity, and the environment that exists that sometimes supports those issues. So thank you very much to the panel again. Thank you everybody for listening. It's been a really interesting discussion, and do please keep in touch. Thank you.